All right, we're going to go ahead and get started with our webinar today. We have our speakers live with us today, and I'm very excited for this webinar. I wanted to welcome all of our participants as well as our individuals that have registered for this live webinar. It's been a webinar that's very much collaboration and planning between Center for Infectious Disease Research and Center for Infectious Disease Research, Infectious Diseases, Society of Infectious Disease Pharmacists, and ProCE. The title that we've come up with is Expanding the Impact of Antimicrobial Stewardship, Act Local. And our speakers today are Dr. Elizabeth Monsees, and I'll get a little bit more into her background and all of her expertise. Dr. Bradley Langford comes to us from Canada today, and then I'm your moderator, Marnie Peterson, from the Center for Infectious Disease Research and Policy. There's a lot of CE that is being provided, and I'll get into thanking our funder of this is with an educational grant from bioMérieux. So I'll get more into details with the slides. So I have some background slides before our presentation begins. Going forward here. Okay. So a few disclosures before we begin. This disclosures, in working with our CE partner ProCE in clinical care options, require that all the individuals that were participating, we provided our conflict of interest documentation, and the relevant financial relationships are reported below. There were no relevant conflicts of interest to be reported from any of the planners or speakers except myself, having reported a co-ownership in a company, Perfectus Biomed. Okay. And then just a little bit about other background and disclosures of unlabeled use. This is an educational activity, may contain discussion of published or investigational uses of agents not indicated by the FDA, and they do not recommend the use of these. This is more of an educational and thought-provoking webinar and conversation. And the disclaimers of participants have implied responsibility to use the newly acquired information to enhance patient outcomes or your own professional development. So our target audience is all of you that have joined us today. It's very broad. It's physicians, it's pharmacists, laboratory professionals, and nurses as well. The learning objectives, these are overarching, and at the conclusion of this activity, you should have a background and understanding to be able to implement appropriate infection prevention strategies, or at least understand these strategies based on antimicrobial and diagnostic stewardship data, be able to describe what data are generated and reported from diagnostic laboratories as it pertains to antimicrobial stewardship, and how do you utilize that data in decision-making and impacting clinical outcomes. And that's the final piece. Both speakers will be trying to connect all this together, the diagnostic data, the stewardship data, with the potential to affect clinical outcomes. And as I mentioned before, we're very thankful to bioMérieux for the funding to support this educational grant, which touches a lot of professions. This is all the CE and CME activity that can be obtained. We are offering 1.25 contact hours, so you will all notice if you've registered for this webinar, we will be going for an hour and 15 minutes. So it's designed to be about 50 minutes of presentation and then another 20 to 30 minutes of Q&A. So you'll have the opportunity to engage. All of you are muted, but you have the opportunity to submit questions, comments, to engage with these speakers through the chat box or the Q&A box via Zoom. So please do that. I'll be monitoring that and preparing questions at the end of their presentations. So there's ACPE, there's also physician continuing medical education, there's clinical laboratory professionals, PACE, and in addition, in our collaboration with SIDP and individuals through BPS, we are offering VCIDP opportunity here for recertification. So we can provide some of this additionally in the chat box, where you can go take your post-test and obtain your recertification credit. Finally, where do I obtain my CE after this event? So you will complete an online post-test and evaluation. The deadline for this is from this webinar. The deadline for you to take the post-test and submit your CE is May 27th, so you've got about a month, and your CE credit can then be uploaded through CPE Monitor. And the attendance code for this is obviously presented at the back end during our Q&A session, and I will also provide it in the chat box. So with that, I'd like to invite Dr. Monsees to begin her presentation. I'm going to stop sharing, so she's going to come forward. Brad's going to go off camera. And then just a brief introduction of Dr. Monsees. Had the opportunity to work with her on a different CIDRAP webinar a couple years ago, and she just brings such a amazing perspective as far as the intersection of nursing and other health professionals and their role in stewardship. So she's going to talk about expanding the impact of stewardship, acting local, but thinking from a global perspective. She's an antibiotic stewardship program manager. She's got several degrees, including nursing, her doctorate degree, and her MBA. She's also well published in the space of engaging nurses in the stewardship in antimicrobial resistance, infection, and infection control programs. And she's also been a part of APIC, their educational committee, and also SHEA's research committee. So if you don't know her before this presentation, you'll definitely want to connect with her and follow her work after this presentation. So with that, Dr. Monsees, welcome. And Carlos wanted me to let everyone know, Carlos is our CIDRAP in the background. He's technology support for our group. He's just wanted me to let all of you know that are listening that this is recorded, and these slides, this presentation will be available on the CIDRAP site as well. So I'll give you more of that information at the end. So that's a little bit of background. Dr. Monsees, take it away from here.
Okay, thank you, Marnie. I so appreciate this. Hopefully everybody can see my slides.
Just need to come off mute.
Oh, can you guys hear me? Everybody? Okay. So I am delighted to be here with you today, and thank you so much for the opportunity to talk with you and have a conversation about antibiotic stewardship, and really to think about how vital
Dr.
it
Monsees,
is.
just 1 second for pause there. I just want to check in with Dr. Langford. Can you hear Dr. Monsees, or is it just me?
No.
I can hear Elizabeth. Sounds good to me.
Can you guys, so everybody can hear?
Yes, go ahead, Dr. Monsees.
Go ahead.
Okay, perfect. Okay, thanks. So I'm delighted again just to be here and to really talk with you about how vital it is to think globally in order to implement local actions. So we'll talk a little bit about that in the next several slides. And so as Marnie mentioned, there's a number of different learning objectives. So for this webinar series, she listed those on the initial screen. So my learning objectives for this webinar portion that I'm sharing with you is really to be able to describe recent antimicrobial stewardship trends that may influence local actions and response. As Dr. Peterson shared, my background is infection prevention and safety. I come with a clinical safety background too. So when I really became immersed in stewardship, I really came with it with those lens. And so considering this series to be very timely, so we'll discuss the synergistic relationship between infection prevention, antimicrobial, and diagnostic stewardship, which if some of you had the opportunity to attend the SHEA conference, was a hot topic. There were a few presentations to this effect. And then finally, just to round out the portion of my presentation is I tend to be a very pragmatic person. So I want to be able to share a few examples of diagnostic stewardship initiatives for the pre-analytic phase. And to give you some options that you might want to be able to explore within your own institution. So as you're likely aware, stewardship is a rapidly evolving discipline. So I'd like to review a few trends that have received attention. First, there have been calls for broad engagement. And so as many of you are aware, oftentimes stewardship falls within the domain of infectious disease physicians and pharmacists, which are a small subset of healthcare professionals. So you can see the image on the left. These highly specialized experts often practice in academic institutions, yet the majority of care, as you know, is delivered elsewhere. It's in ambulatory, it's in community care, maybe rural health. And the one discipline that is constantly present across the board are nurses, which have had recent attention in the past couple of years as an untapped resource for supporting stewardship endeavors. The second thing is really having better metrics to reflect the patient experience. So a common stewardship metric is the evaluation of days of therapy as a reflection of antibiotic consumption, but they oftentimes fail to represent the appropriateness or impact to frontline clinicians. And I think there's a push within the stewardship community to develop safety measures which reflect patient harm. And there have been some nice data that's come out of Johns Hopkins that 20% of both hospitalized adults and pediatrics experience antibiotic-associated adverse events. Third, there's new methods to strengthen the science. So there's been some nice publications. In fact, Shea came out with a white paper this year talking about leveraging implementation science to advance the antibiotic stewardship research and practice. Other strategies that have included with this are qualitative methods to explore communication, relational dynamics between stewards and prescribers. So I think we're going to continue to see this really evolve in different types of methodologies to explore this topic. And then finally, the word stewardship really seems to be a hot term, and you're seeing it referring to prevention strategies, so immunizations, contributions to develop COVID treatment and testing algorithms, personal protective equipment or PPE stewardship, which sometimes stewards are using during their stewardship rounds and evaluating PPE use. Handshake stewardship, which was developed by Children's Hospital Colorado as a rounding-based antimicrobial service that really kind of creates a really nice relationship between the frontline clinicians and the stewards. Ambulatory stewardship. So my own institution has partnered with 50 different children's hospitals to share learning to advance stewardship in that particular practice area, so the ambulatory environment. And then lastly, diagnostic stewardship, which involves the process of ordering, performing, and reporting diagnostic tests to improve treatment of infections and other conditions. So as mentioned, those antimicrobial stewardship trends are also being reflected in diagnostic stewardship practice, where the CDC identified in the 2019 core elements that nurses can and should be included in diagnostic practices, particularly around optimizing microbiology cultures, which in turn, as you know, leads to improved antibiotic use. So again, coming to stewardship about 6 years ago from infection prevention and safety, those two domains oftentimes have standards and metrics to describe patient harm. And so, again, we think about central line events or central line associated bloodstream infections, so CLABSIs or catheter associated urinary tract infections, CAUTIs, or serious safety events from the clinical safety aspect. But in stewardship, sometimes I have found it hard to describe where and what we need nurses and other clinicians to do to intervene. And so my hypothesis for some of this work is that for broader engagement, stewardship harm metrics may be necessary. And there's been a couple nice publications from Dr. Pranita Tama out of Johns Hopkins. I think that was published earlier this year. So my slide is really showing that when we conducted the review of the literature in 2017, really at that time, we only found about 13 articles across the globe that demonstrated nursing contributions to stewardship. And there were a number of barriers identified, but mainly patient safety culture inhibited their ability to participate, and same with education. Fast forward, there was a new article from Rita Olens in 2020 that showed an exponential increase in the number of publications that referred to nurse or nursing inclusion in stewardship. However, those journals are largely non-nursing. So among the nursing journals, those numbers are relatively static. So you can see that in the red line. So in other words, epidemiologists are demonstrating the value of nursing inclusion, yet nurse-to-nurse conversation via peer-reviewed journals isn't really changing. So my experience and what we're seeing from some of these publications is that nurses are oftentimes interested in participating both in antibiotic and really recently in conversations I've had with them around diagnostics. But the question oftentimes that I receive is, what are we specifically trying to improve? They're familiar with the quality improvement pathways. And so, we improve CLABSI rates. We want that to go down to a certain level. So stewardship, it makes sense that we may need some measures that also helps these other disciplines understand where they might be able to intervene. And so I think that really brings us to how do we potentially raise the attention for these topics. So this is a really nice study from Dr. Valerie Vaughn and colleagues that describe the composition of stewardship teams. And you can see in blue which reflect small hospitals around 50 beds or less, to large hospitals shown in gray, 250 beds or more. And you can see hospitalists, other physicians, nurses really hover around a 50% participation or less. ID pharmacists are found more present in larger hospitals, but oftentimes are not as present in medium or small hospitals. Yet the one discipline that is routinely found on stewardship teams is the infection preventionist, regardless of hospital size. You can see that represented on the left-hand side, which is one of the reasons our learning goals is really to be able to describe the intersection between infection prevention and antimicrobial and diagnostic stewardship. So at APIC, Shea and the Society of Infectious Disease Pharmacists published in 2018 was a position paper. And they described the importance of stewardship and affiliated stewardship of diagnostic testing to really be able to slow the emergence of resistant organisms, reaffirming the fact that infection prevention and antimicrobial stewardship really are synergistic activities. Furthermore, the authors state, IPs have substantial contact with bedside nurses, to which they can leverage those really strong collegial relationships to influence nursing's supporting role in stewardship. And that can be through patient education, talking about patient transitions of care, and a variety of other activities that aren't listed here. And so we know that IPs are really spending a substantial amount of time actually supporting stewardship per month. So we had a survey, we put this out to a fair number of APIC members, and what we found is that, not surprising, activities like data analysis, surveillance, and public reporting really fell quite high on the IP's list. So they're spending more than 5 hours a month doing any one of those activities. In our survey, we found that approximately 19% of IPs reported spending more than 5 hours a month educating nurses on appropriate microbiology specimens, cultures, or even rapid molecular testing. So this is a nice figure that comes from Dr. Mary Jo Noblick. And what she identified is that, again, there's a lot of similarities of practice between stewardship and infection prevention. And so has proposed this collaborative framework that both stewardship and prevention require distinct and a unique skill set. Both collaborative teams are built on trust, common understanding, open communication to really achieve that shared vision of reducing healthcare associated infections. Infection prevention, really is oftentimes focused more on system level approaches. And that's largely driven by regulation and accrediting agency. You're working with, folks from environmental services all the way up through administrative leaders to address multiple issues throughout the organization. Whereas stewardship oftentimes focuses on individual decision making. However, I think, many of you might say that we're starting to see more and more publications that are describing larger system change and larger practice changes than just the individual. So I think, again, this is evolving too. At least I've seen that within the past several years. So now that we've discussed antimicrobial stewardship and then the infection prevention intersection, now let's layer in kind of that diagnostic component too. So this is a nice viewpoint from clinical infectious disease, that diagnostic stewardship is really an integral part of antimicrobial stewardship efforts. The authors refer to diagnostic stewardship as ordering the right test for the right patient at the right time to inform optimal clinical care. And that can be done by applying these true north components for care delivery. And that's described by Dr. Donna Volk. And that begins with a decision support and risk stratification process by applying diagnostic subject matter expertise to really generate and produce value-based care, by designing interventions that leverage speed and accessibility through patient impact. And then that impact can also be, not just antibiotics, but radiologic, and then common hospital indicators like bed availability, and ending with quality and financial stewardship. There's just a really nice summary article by Dr. Andrea Prenzi, and I've included a link within this slide as well. Another figure that illustrates the synergistic relationship between prevention and stewardship comes from the Netherlands by Diek and colleagues, who proposed antimicrobial, infection prevention, and diagnostic stewardship, or an AID approach to infection management. And I really like their flow chart. And basically what they're depicting is a path from the patient beginning at the very top, so the possible infectious problems, all the way through the bottom, the successful management of the infectious problem, and then several building blocks of those 3 supplemental stewardship programs. So again, you can see infection prevention, that's in the pale green, antimicrobial stewardship in kind of a pinkish blush, and then diagnostic within the blue. The authors really encourage us to really demonstrate how intertwined the necessity of all of those different types of programs are in the integrative model of what they've proposed. So when I think about my own organizational work, I tend to refer to Dr. Morgan's JAMA article quite a bit. So we had a nice viewpoint article published a few years ago, thinking about diagnostic stewardship to leverage the laboratory to improve antimicrobial use. And again, he describes this as system user-based interventions to promote evidence-based utilization of diagnostic tests with the potential benefit of reducing false positive results. So again, that doesn't mean that it's only the function of laboratory professionals. What Dr. Morgan and colleagues have described is 3 approaches to diagnostic stewardship, and you can see those listed there on the left. One is pre-analytic, which encompasses ordering and collection. Then there's the analytic process, referring to specimen processing. And then finally, the post-analytic, which provides reports to guide practice. And my co-presenter, Dr. Lankford, will address post-analytic work and that really tight relationship with antimicrobial stewardship. But let's take a moment to really flesh out the pre-analytic part. So that's testing only if a clinical presentation is consistent with an infectious etiology. So for example, Clostridium difficile. Testing, or Clostridoides difficile, sorry, when a disease is likely. So clinically, there should not be a laxative use. They should not be testing for a cure. This section also involves clinicians because of that ordering and refining piece of how the specimen is to be collected to also reduce contamination. So as an infection preventionist many years ago, I was often asked by folks, how do I actually obtain this specimen? Is there guidance of what it should look like? For example, with CDI, it conforms to the shape of the container, so you should not be sending down from stools and so forth. In the pre-analytic phase, also, again, I think broadens that scope beyond infectious disease and laboratory professionals. As we started, it was shared that diagnostic stewardship, yes, it's certainly something that was in the lab. So when I've talked with people within my own facility, they've said, Elizabeth, we are doing diagnostic stewardship. I'm like, absolutely. Our laboratory folks have been experts in this for a long, long time. But when I'm thinking about it from a practice standpoint, and why our CLABC group is saying, why are we ordering all these different tests? How many are actually being done from the central line and so forth? Because we're calling these data events downstream. I think this viewpoint is a really nice article to be able to illustrate. We're actually talking on the front end, so the ordering piece, and then assuring that that collection is done seamlessly. And so again, I think there's a reasonable focus for nursing and infection prevention partnerships because nurses obtain the test and IPs are oftentimes responsible for interrogating those results as part of their surveillance work. So those data points, CLABC, CDI, CAUDI, and so forth. And then, just to also let you know too, is that you should expect some publications to come out this year. Doctors Morgan and Diekma are leading a diagnostic stewardship working group. And so to give a little bit more guidance to that, so stay tuned for that. So when we talk about pre-analytic examples, let's explore that in relationship to our diagnostic and antimicrobial stewardship work. So we know from antimicrobial stewardship and infection prevention that nurses value algorithms to guide practice. And so you can see a couple references there, particularly urine cultures in adults. So that's been a nicely studied topic. And a new one that just came out from Valeria Fabre out of Johns Hopkins, which had a pilot study to look at the impact of nurse-driven urine cultures and diagnostic stewardship interventions. I think there's a nice example of this work too, is just really being able to help nurses identify the impact of why these specimens are collected, and then downstream, how we're actually then interpreting these data and adjudicating them as healthcare associated infections or not. And when I was going through my doctoral work, I spent a lot of time with my advisor who actually had more of a focus in geriatrics. And she said, Elizabeth, the issue that we run into is that people are doing these urine cultures because, the urine smells funny or whatever the reason might be, when in fact the patient may just need to simply be hydrated before we actually get a specimen and then, identify that they have a urinary tract infection, which may not be accurate. And so again, trying to help parse out some of these clinical features along with the diagnostic data may be a really important piece of the pre-analytic work as well. Coming from my own hospital, bedside nurses participated in the development of a pharyngitis clinical path guideline to minimize the broad testing of children with group A strep. And then, from infection prevention, nurses have a long history of developing care bundles to prevent the development of central line-associated bloodstream infections, so CLABSIs, or catheter-associated urinary tract infections, CAUTIs. So as Dr. Fabre identified, most blood culture improvement initiatives oftentimes focus on the collection process, which are oftentimes nursing processes, right? We're looking at fill volumes, so we're not just tinging the fluid just to make sure it's pink and then we can send it off because it was very difficult to access and obtain a sample, to aseptic technique. But very few studies that she reports focus on interventions that reduce blood culture utilization, which is a common concept for many IPs because they oftentimes evaluate and report device utilization. And I think I appreciated this when she published her paper because, reflecting on my own CLABSI work, we oftentimes discuss very tactical practices, but not, as Dr. Fabre identified, why the specimen was actually ordered in the first place. We do root cause analysis on all these different practices, but what actually led up to it? Was it just simply part of routine management? Was there actually a change in the patient's condition that led to this? And so I just think that there's just a really interesting place where we can begin to explore what promotes some of these different collection techniques. And so we're seeing blood culture utilization improvement work come from additional colleagues from Johns Hopkins too. So this is pediatric work by Dr. Charlotte Woods-Hill, which examined whether a two-part clinical practice guideline could decrease total rates of blood cultures, those collected via the central line. The primary outcome was the total number of blood cultures divided by the patient days. And since this was a pediatric intensive care setting, they also examined sepsis as a balancing measure, just to make sure that the process change didn't result in missed sepsis cases. What I found very helpful in this publication is that they created this fever sepsis screening checklist, and so I've shown this here, as well as a blood culture decision algorithm. It's meant to really support a standard structured approach to the patient. So with the onset of a new fever or a change in a clinical status by the nurse and the provider. So I've highlighted it there. So by design, it's really to have a clinical dyad between the nurse and the provider that review those, whether a blood culture may be warranted or whether a blood culture may not be warranted. And in my experience, this is oftentimes where nurses ask these questions. And in fact, when I'm talking about antibiotic stewardship, and I say, we're starting these projects just to begin to explore specimens, again, what we might be able to do to help improve some practices around this. And they said, this is exactly what we want to hear because, we're wondering, why are we getting the specimen? How many are needed? How many lumens? Or if the same specimen was just done yesterday, why are you getting another one for this? And so what we found from this work too is, the two-part intervention was very effective. And in fact, there was almost a 50% reduction after introducing the checklist and the algorithm. And so you can see that on the top part is the total number of blood cultures, again, over calendar time from 2013 to 2015. And then the bottom one is actually the number of specimens that were drawn from the central line. And they found significantly fewer cultures that were collected from the central line. So again, if we're not accessing the line, we have less risk of CLABSIs and other types of complications. And so again, I just think it was a really nice effort that really showed an interprofessional collaboration. They were actually able to repeat this in 3 other ICUs at 2 different sites, and then has led to a 21 hospital collaborative partners entitled Bright Star, and I've included that link here too within the presentation. So, and I believe the next series, I heard Dr. Woods-Hill present, I believe they're also looking at the relationship of this work to antimicrobial use. So again, I mentioned I come to stewardship with the mindset of this interprofessional, again, how do we communicate with others? I think that's drawing from that safety and infection prevention standpoint too. So in respect to diagnostics, again, Dr. Fabre, who's published quite a bit in this area, has found that many respondents believe that a blood culture are an expected part of a patient's workup. So I don't think that's probably too surprising, right? And then she identified that there are decision-making for blood cultures was really multifactorial. It was influenced by provider roles, by years of experience, by locations, whether they were in the ICU or not. But few respondents felt order sets or communication between prescribers or prescriber to nurses would improve blood culture practice. And I mentioned this because I found this survey to be interesting, because I think we do have some nice data from BrightStar and from other work that indicates the effectiveness of this really interprofessional engagement. And as such, that's really what I've used to inform work that I'm doing within my own hospital. And so really this was born out of advanced practice nurses who really identified that there was variability in who was collecting specimens for certain patients or not. And nurses were coming to them either as, the subject matter experts in the ICU, and then we had some in our DI clinic. And they said, I've noticed on this patient, they're getting these specimens, on this patient, we're not. It seems like they want 2 specimens, they want multiple specimens. And it's just very confusing to the frontline folks to know, what is the expected practice and how they can implement that moving forward. And so really what I did is I worked with our an infectious disease physician and a wonderful pathologist. We also have a laboratory professional and a researcher in that area and an infection preventionist. We secured an administrative champion who connected us with PICU leadership, and then ultimately an intensivist that is also working on CLABSI work as an interest in quality improvement. And she's just been a phenomenal partner with this work. And so we're very excited about beginning to, again, just evaluate this in the ICU to see, is there an opportunity where we might be able to intervene? So what we're doing is essentially same things that were listed within the BrightStar Collaborative, is being able to return to that patient safety team science, so identify additional influencers to help guide the project. We're currently working on analyzing blood culture data. Our CLABSI hack was very interested in central specimens. So how many specimens are we actually drawing from the central line? And then being able to pair that with outcome data like CLABSI. It was actually very enlightening as I started doing some of the analysis of how many specimens there were. So, from a central sample, there can be a blue lumen and a white lumen and all these other, colored brown port and so forth. And it was very hard, even as a nurse, to be able to discern which ones are central specimens when these specimens were obtained. And actually what was really interesting too, approximately a quarter of those blood cultures simply had blood. So in other words, a blood culture with source blood. And so we worked with informatics to limit those options and to really kind of pare down that list, so we could be able to beginning this year, to look at the number of specimens that are drawn from a peripheral versus a central line. So there might be opportunities within your own institution just to kind of fine tune some of the different options that the frontline providers can select. And then finally, we're in the process of developing an algorithm to help nurses and providers determine whether a blood culture may be relevant, and then also evaluating how likely are folks to be able to use these data to inform their practice. And so as I close, we've addressed trends and practices for the pre-analytic phase of diagnostic stewardship. And together we've explored the intersection between infection prevention and antimicrobial stewardship. And I just want to leave you with, our professional organization for infection preventionists. So that would be the Association for Professionals in Infection Control and Epidemiology. So APIC includes stewardship in the very broad sense as an IT competency. And I think that becomes important just for you to know, because I know that there's a number of different disciplines that are represented on the webinar today, that your IP does have some exposure to, again, professional stewardship. But I think what, as Dr. Mary Lou Manning illustrates within that position paper from Shea, from APIC, and Society of Infectious Disease Pharmacists, that the linchpin of this work is really that strategic relationship building, which required both infection prevention and stewardship leaders to achieve the larger purpose of keeping patients safe and ensuring effective therapies are available for future generations. And with that, again, I hope we were able to talk about that relational part. And I would love to take any questions I know at the end. And I've listed my email here as well. And so again, thank you so much for this opportunity.
Thank you, Dr. Monsees. Appreciate so much your presentation. Dr. Langford's going to be sharing his slides and continuing on with our webinar. And I just wanted to mention to the participants, in case you joined after we began, that this presentation is being recorded and will be available on our CIDRAP website as well after this recording, after the presentation. And yeah, questions and comments from all of you, please provide them through the chat box or through the Q&A button, because we'll be having about 20 to 25 minutes of Q&A at the end. And I really want to hear from you as this presentation stimulates some of the questions you may have. As you see, Dr. Monsees is very much an expert in the field of infection control and some of the pre-analytical, especially diagnostic stewardship and that connection. But now we're transitioning to Dr. Langford. So I'm so pleased that he took time out of his busy schedule to be a part of this with us. He's going to talk about the post-analytical diagnostic stewardship. A little bit about Dr. Langford. He's has his pharmacy degree and his PharmD degree, and also board certified in pharmacotherapy specialist, BCPS. He's the lead pharmacist for Public Health Ontario's Antimicrobial Stewardship Program. And he's really, his role is the advancement of antimicrobial stewardship across all sectors in his province. He leads his team at the hospital. And he's very much interested in the evaluation of antimicrobial stewardship outcomes and the diagnostic data that goes in to provide the stewardship activities and outcomes and how they can be implemented to improve overall patient health. I also wanted to mention Dr. Langford, in case you don't know, he's very interested in the use of social media, and he spreads his message about stewardship through Twitter. He's got a, you can find him on Twitter at BRXAD, as well as hashtag ASP chat. He's got a monthly Twitter chat that's focused on antimicrobial stewardship. So it's very unique to you, Dr. Langford, and that you're so active on social media. So I wanted to mention that to the participants so they're readily able to follow you and what's currently your monthly hot topic. So with that, I'm going to turn it over to you, and we'll let you begin.
Great, thanks so much, Dr. Peterson, for such a great introduction. And thank you, Dr. Monsees. You did an awesome job talking about the concept of diagnostic stewardship and how stewardship programs and infection preventionists can both support pre-analytic diagnostic stewardship. So now we'll shift gears a little bit to talk about post-analytic diagnostic stewardship, and that is after the results are available. How can stewardship clinicians, particularly physicians and pharmacists, help to support improved patient outcomes? So our objectives will briefly discuss data that are generated by diagnostics laboratories. We'll discuss the role of nudging and knowledge translation in supporting diagnostic stewardship. And then I'll give you some practical examples of how these approaches have been used from a post-analytic perspective. So these are some of the stewardship opportunities we'll briefly discuss: selective and cascade reporting, interpretive comments and other nudges, antibiograms, and prospective audit and feedback, which I think are all kind of part and parcel of the post-analytic diagnostic stewardship approaches. So a talk about diagnostic stewardship would not be complete without mentioning the concept of nudging. Richard Thaler and Cass Sunstein made this term famous in their 2008 book called Nudge. And the definition of a nudge is essentially the modification of choices, or what they call choice architecture, to predictably alter behavior without forbidding any options. So things like mandates or restrictions are not nudges. Nudges are a little bit more gentle than that, and they, in some cases, can be just as effective. So as an example, think of a restaurant that defaults to offering a salad rather than fries as the default choice to go with your meal. Or think about in a grocery store, the requirement to post nutritional information on all food labels to help guide healthy food choices. Or finally, a school cafeteria putting the fruits like front and center rather than the chocolate bars, so that they're easy to see and reach for the kids. So you can tell food is on my mind, but there is a corollary here with diagnostic stewardship, in that labs can report defaults as well. So through selective or cascade reporting, they can also provide additional information, including interpretive comments on the reports. And then they can provide therapeutic options at eye level, so bolding the options or putting them at the top of the list, rather than simply alphabetical, that can help to influence prescribers' decision-making. So what are some of these best practices with respect to default choices? And default choices is really the microbiological equivalent of offering that salad instead of the fries. So CLSI M100 provides some information on this, and they give you groups of antibiotics that can be used for routine reporting, and they call those group A antibiotics, and reporting only when the first line options are not appropriate, and they call those group B antibiotics. But these lists, if you've seen the CLSI M100, they're fairly broad, and they really need to be adapted to your local context. Similarly, Infectious Disease Society of America, or IDSA, acknowledges that we can use things like selective and cascade reporting, but the data are limited in terms of their impact on clinical outcomes. So we need to make sure that when we implement them, there are no unintended consequences. So what are the data so far that we know about that support some of these nudging strategies? Our team in Toronto, we formed a research program that we called NIMBLE, which is Nudging in Microbiology Laboratory Evaluation. And our first effort was to perform a scoping review to get the lay of the land on nudging strategies that have been published in the literature, specifically as they relate to microbiology. So this is a visual abstract of our paper that was published in ITCHE a few years ago. And we identified 15 studies and found that selective and cascade reporting was certainly the most common approach that was studied. Other approaches like providing comments, so for example, stating that this culture likely is contamination or colonization, was only performed in 2 studies. What we found was promising about most of the studies that we looked at is that many of them showed that these strategies of nudging did improve antibiotic prescribing behavior. But we also identified some gaps in the literature, that there's still a lot of work to be done to implement more innovative approaches, perform higher quality prospective studies, and then look at how can we nudge in the outpatient setting, and how can we evaluate clinical outcomes to know that indeed this is improving patient care. So what are some of the examples that have been used in hospitals and are kind of recommended approaches for nudging? On the left-hand side, we have selective reporting, and on the right-hand side of the slide, you have cascade reporting. Selective reporting is more of a fixed approach, regardless of the susceptibility results on the panel. So for example, there would be some standard approaches to not reporting certain bug-drug combinations that are not clinically appropriate. So not reporting daptomycin susceptibility for pulmonary isolates is kind of a good example of selective reporting. But in contrast, on the right-hand side, you have cascade reporting that's a little bit more dynamic and depends on the susceptibility pattern for that particular patient's isolate. So I acknowledge that narrow and broad spectrum antibiotics are somewhat loaded terms, but cascade reporting kind of embraces this concept of reporting the relatively narrower spectrum options first, and then only reporting broader spectrum antibiotics when there is resistance to the narrower spectrum antibiotics. So some examples of that would be only reporting carbapenem susceptibility results when there's resistance to third-gen cephalosporin, for example, or only reporting amoxicillin clavulanate if the organism is resistant to amoxicillin. So hopefully these approaches are meant to guide appropriate decision-making through a default type of process. I should mention that with cascade reporting, it's generally recommended as a best practice to report antibiotics to which the organism is resistant, because we don't want clinicians wrongly assuming that just because it's not on the report that it's in fact susceptible. That's kind of an important caveat to cascade reporting. So our team recently did a large cohort study that looked at how these laboratory reporting processes can influence prescribing with respect to urine cultures in the outpatient setting. And we looked at 113,000 urine cultures from 48 laboratories in the province of Ontario. And we found a pretty substantial degree of variability across the laboratories in terms of how they report antibiotic susceptibility. We found that when laboratories reported a certain antibiotic on the culture and susceptibility report, so for example, fluoroquinolone, there was a threefold higher odds that the clinician would select that antibiotic compared to if it was not on the report. So this really reinforces that concept of out of sight, out of mind, in that labs have this largely untapped opportunity to influence prescribing choices using selective or cascade reporting type of approaches. Another interesting approach related to selective reporting is simply not reporting culture and susceptibility results at all for certain scenarios. And more specifically, this example here is called modified reporting. And the example here is for midstream urine cultures from inpatients, replacing that usual E. coli are susceptible to X, Y, and Z agents with this comment indicating that tests are often reflective of asymptomatic bacteriuria, and if clinicians suspect that their patient truly has an infection, to call their laboratory. So there's actually a few preliminary studies to point to this practice being safe and effective when used in the right population. And so the right population is likely non-pregnant, non-neutropenic adults outside of the ICU setting. And this is a fairly large proportion of many of our hospitalized populations that represent a lot of urine cultures that are sent, most of which those urine cultures are largely representative of asymptomatic bacteriuria. So these modified reporting approaches can lead to less treatment of asymptomatic bacteriuria, and there seems to be so far no evidence of undertreatment of urinary tract infection. I should note that though in catheterized patients, this practice has been found to be not as useful as it doesn't provide as high a yield in terms of improved patient outcomes. So shifting gears a little bit to framing and providing interpretive comments on reports. Most labs will have some sort of interpretive comments that they provide when they report out culture and susceptibility results. But I think there's an opportunity here to be more consistent with a focus on how we can improve antibiotic prescribing behavior when we construct these reports. These are a few really good examples that I've found that can encourage better antibiotic stewardship. And on the top left-hand corner here, I really like this example by Mary Musgrove and her team on simply changing the commensal respiratory flora comment to commensal respiratory flora only, no Staphylococcus aureus or Pseudomonas aeruginosa. And so that simple, no-cost initiative that calls out, there's none of these particular organisms that you may want to cover for these organisms are not here in this culture. This is a simple initiative and it resulted in a 5-fold increase in de-escalation of anti-MRSA and anti-Pseudomonal antibiotics. Similarly, some interpretive comments like indicating contamination. So for example, for urine and blood cultures can be very helpful to guide antimicrobial stewardship. And another example here I have here on the bottom left is the use of reference ranges. Here I've cited a paper in which procalcitonin was used, and they inadvertently in this hospital used a lower reference cutoff of 0.09 nanograms per mil, which was from the product monograph, instead of the cutoff that they actually used for part of their hospital's algorithm of 0.25. So this resulted in high levels higher than 0.09 being flagged and show up as red in the chart, which would trigger more antibiotic use than was necessary. So it was a simple misalignment that can lead to incorrect clinical interpretation in antibiotic overuse. So something to be quite mindful of. But of course, antibiotic stewardship is not just about less antibiotic use, it's about more appropriate antibiotic use. So on the right-hand side here, I have some examples of encouraging optimal antibiotic prescribing, including the use of interpretive comments to suggest infectious disease consult for Staph aureus bacteremia, and the use of cautionary comments on organisms that may have inducible AMP-C beta-lactamases. These can be quite helpful when added to the comments on the report. So next is antibiograms. Antibiograms can be considered a post-analytic approach. So after the post-analytic approach to help support future empiric prescribing decisions. And the feedback that I've generally received from clinicians is that antibiograms need to provide more practical advice in the context of their particular patient scenario to be truly useful. Sometimes it's a little bit too much to provide a large table with a jumble of bugs and drugs and numbers, and it's hard to sometimes interpret that. So what can be more practical is integrating information from the antibiogram itself into the prescribing process. So into the clinical decision support system or into CPOE, computerized physician or provider order entry. We can also help clinicians interpret antibiogram results by providing education when new antibiograms are released, and also providing one-on-one support in understanding the antibiogram through use of patient cases, as well as prospective audit and feedback. So one approach that I found to making antibiograms easier to use is the concept of weighted incidence syndromic antibiograms, or WISCAs for short. And a WISCA is like a typical cumulative antibiogram, but it's usually for a given clinical specimen. So for example, urine in this case. And instead of, or in addition to a bunch of rows with all the different organisms, there's a single row that combines all of the organisms into one. And this helps to improve the ease of the interpretation, because clinicians are not always sure, especially for empiric prescribing, what organism they should really be focusing on. So WISCAs can be helpful from that perspective. And I think antibiograms can be made even more useful by allowing for stratification based on the specific patient population. So for example, the specific age group or healthcare setting or region in which the patient is in. This is an example of an antibiogram that we're working on for the province of Ontario that allows the user to decide their population of interest to get an antibiogram that is most applicable to them. And I didn't show it here, but another example of customization of an antibiogram is the use of an escalation antibiogram, which basically will provide a next step empiric option in the situation of non-response. So for example, you have a patient who's treated empirically with ceftriaxone. What would be the next appropriate treatment option in the event of treatment failure? So these are some examples, I think, of how we may begin to see what I call like antibiograms 2.0, where we can apply these data in a more personalized approach by using data about that specific patient population and even patient-specific data like previous culture results to help optimize our empiric treatment selection. And because, as I mentioned, providing rows and rows of data are not always the easiest ways to disseminate information, stewardship programs can also help to provide newsletters, infographics, or fact sheets to go along with the antibiogram to help drill home some of those take-home messages. And this is an example here of a fact sheet accompanying an antibiogram at one of the institutions I support, talking about some key messages related to first-line treatment options for UTI, fluoroquinolone resistance, and the rates of MRSA versus MSSA in that institution. So what I've found is that having information when it is needed the most can help support knowledge translation. So from a high-tech perspective, this includes embedding the recommendations that we have into the computerized physician order entry, for example. That's a high-tech approach. But a more low-tech approach here is adding recommendations onto the pen that will be used to write the antibiotic orders. And this is an example of a pull-out sheet on a pen with the antibiogram on it and some key takeaway points that was distributed to all prescribers at a community hospital. And of course, my example here is not to say that everyone needs to be distributing a pen, but this is just to illustrate that there are some creative ways that we can use to get messages in front of prescribers when they need that information the most. And I've added prospective audit and feedback here, and it's not really considered a traditional post-analytic strategy, but I put this in here because I think diagnostic and antibiotic stewardship, as Dr. Monsees alluded to, is really a team approach, and it involves liaising between the laboratory and the clinician. And I think prospective audit and feedback can really help to make this connection. So for example, we know that rapid diagnostic testing on its own is much less effective than rapid diagnostic testing in combination with antimicrobial stewardship programs. And I think the same can be said for other laboratory processes. Prospective audit and feedback can help clinicians interpret diagnostic data in the context of their specific patient case. And I think even more importantly, the goal of prospective audit and feedback that we should be embracing is to empower clinicians to be stewards when us stewards are not always around. So in summary, here's a brief infographic I kind of made for this talk, is discussing some of the concepts we've discussed. So nudging plays a significant role in stewardship from a lab reporting perspective. It includes strategies we talked about, such as selective and cascade reporting, framing and eye-level approaches. And taking laboratory data and supporting knowledge translation is a more distal but equally important post-analytic strategy. And so things like the use of cumulative antibiograms and prospective audit feedback can really help support the role of the laboratory in antimicrobial stewardship. And of course, the success of these efforts will depend heavily on the collaboration between the microbiology laboratory, infection preventionists, and antimicrobial stewardship team. And you may know that neither Elizabeth nor I are microbiologists, but we work really closely with the microbiology laboratory to help support implementation of these types of strategies. So with that, I'd like to close and thank you for your attention. And I guess I'll turn it back to Marnie for a question and answers.
Excellent. Thank you, Brad. Lots of questions coming in. So Elizabeth, I'll ask you to come back on with your video and unmute yourself here. Excellent. So please continue to send us your questions through the chat box. We have about 15 minutes for Q&A, just maybe 17 minutes here. But Elizabeth, I'm gonna start with you with the question around as you start to try to understand when is the appropriate time to actually draw, in the pre-analytical side, draw that blood culture or collect the urine sample. As you continue to optimize that, I'm wondering, when you start to compare data year over year, from doing that so effectively, you could end up with more cultures that are actually positive for organisms. And with that, because you're honing in now on the appropriate draws, so they are people that maybe are more likely to be infected, that could also lend you to have more cultures that may have antimicrobial resistant pathogens. So what are your thoughts around making sure someone doesn't feel misinterpret data to thinking that we've got more positive cultures, more AMR occurring, because you're literally refining who and when these cultures are obtained?
Yeah, I think that's a really good point. So I think what we're trying to do right now is just to kind of get a sense of what the baseline is, because we really just don't even understand what the frequency is within our own institution of how many blood cultures are drawn at any particular time. We actually, in a related note, we are actually doing a similar type, we're actually doing a research study looking at tracheal aspirates, because, and that was born out of the lab. They're saying, gosh, it takes us forever to speciate some of these things. And we're finding, like they're doing them day after day, repeated tracheal aspirates, and we're not sure if people were actually intervening. And what we found in just the preliminary data, to your point, is that, you know, people are receiving a higher number of repeated aspirates, and that they are seeing a little bit more resistance because they're being placed obviously on antibiotics for other conditions too. And so all that to say is, I think, you know, I don't have an answer for, you know, as far as seeing more resistance other than being able to look at historical stuff. But it's really just to try to understand where our baseline performance is. I don't know if that was quite getting to your question, Marnie.
No, it does. And I just think it's not cautionary, it's just to understand that as you get more algorithms and more sophistication of, if you will, and data to support when to draw or not to obtain cultures, that it could, if you're doing it really correctly, then it could lead to a higher likelihood that you'll get a positive culture when you anticipate it should be positive. And you know, then you could be a hospital or a region that has, of all the cultures obtained, you end up with more positive because you're simply not collecting all of those that were negative in the first place.
Fair enough. I think that's why we also have some additional parameters too, to make sure that they're collecting specimens appropriately. Because again, in pediatrics, you know, like I mentioned, like sometimes it's really hard to get blood out of a really tiny baby. And so, you know, you're coloring the water, and so you're not even getting an appropriate specimen. So I think to your point is, you're right, we could potentially have more, but I think there's just still a long-term work that probably still needs to be happening, getting those specimens done.
Yeah, and just to clarify, it's not to be negative at all. I'm
no,
just
I
saying
didn't.
The whole data set could shift because of that more precise draws. And that ties to me into your talk, Brad, where you're talking about, you know, post-analytic, the way that you're dealing with some of that is with your modified reporting. So with, you know, when antibiotics are not a solution, and how to determine how to report, when to report that with your modified, I'm getting to your slide here, but just this modified aspect of modified reporting is a way of also you're dealing with potentially those cultures that are due to contamination or other things that Elizabeth and her team are trying to affect on the post-analytical piece.
Yeah, ideally, you want to get to this upstream, and pardon the pun, but I guess it is a pun. You want to get to, you know, addressing urine cultures right from the get-go, so not sending them when they're not needed. Modified reporting is kind of an after-the-fact approach in the situation in which urine cultures may be sent more than they're needed. And I find, and I'll be honest, actually, I've tried to do this in my own setting, and we haven't been able to implement it yet. It's been only implemented in a few sites within Canada, but I think it's a very promising approach to try in specific settings where, you know, where you have inpatients without catheters, and your laboratory is supportive of such an approach, where you can respond to calls, like say after hours, if somebody needs to know, well, what was that urine culture, because it doesn't say anything on it. You can call at 2 a.m. and find out what that information is. So I certainly would put an emphasis on the work that Dr. Monsees mentioned over the modified reporting, but I thought it would be interesting to share this approach. Maybe could be useful in tandem with other pre-analytic strategies. Absolutely,
and I think that is having you both on this presentation at the same time shows the importance of having the tie with infection prevention and pharmacists and clinician and laboratory all interconnected. So question for you, Brad. You presented the cascade reporting, and one of your examples was when you have ceftriaxone resistant, you may report that there's the carbapenem is the single option there. Do you ever, the question is that the individual's basically making a comment saying that they've seen the problem where those antibiotics that you don't report as an option, that are the clinician or the prescriber may assume that they weren't reported as resistant. And as you said, if they're resistant, you're going to report them. And then you lead the prescriber to maybe a single option initially. But since other antibiotics they may be thinking about aren't reported as resistant, they may assume they're susceptible and prescribe away from your solo mentioned, like a carbapenem as your option.
Yeah, that's certainly a limitation. And I've seen this in cases with urine culturing where For example, a clinician wants to use a fluoroquinolone and we didn't report the fluoroquinolone because it's our process now to suppress the result of the fluoroquinolone. So once the culture result comes back, they're like, oh, it's not here. I need to know if it was susceptible or not. And then some people may make assumptions. So the laboratory certainly needs to be on board in terms of implementation of these approaches, and that they may receive phone calls to clarify, okay, you didn't report a ciprofloxacin, what is in fact the susceptibility results. But my feeling is that generally the out of sight, out of mind kind of adage is true here, and that if you're initiating antibiotics on the basis of a positive culture result, this actually happens a lot in some of our facilities in Ontario, that your initiation will be based on what's shown in front of you. So if fluoroquinolone is not there, what we've seen is that it's less likely to be prescribed because it's simply not reported on the culture and susceptibility report. I'm not sure if that helps.
Yep, no, absolutely. I think people are also trying to implement, seems like from the questions, they're trying to implement some of these practices, and then, you find out there's other behaviors that develop. I think with another question, Brad, for you is with the integrative antibiogram that you've got, it looks like across the whole province of Ontario that you presented there.
That's correct.
Yeah. Which is terrific. I'm so happy you shared that with us. A couple questions that I'm going to try to compress some of these. How frequently is that updated? What software do you use? And since you can differentiate it down, it looks like you can differentiate down to a particular region or hospital. Do you ever have one hospital or one area that has a lot of resistance that skews your overall database? So there's like 3 embedded questions there.
Yeah. So I'll answer the program that we use for reporting out the data. It's a Excel spreadsheet with a pivot table. So it's super low tech. And so I think that's something that can be used in other settings. But I guess something that many other settings may not have is we have access to a large administrative database in our province that is now just beginning to provide us with culture and susceptibility results for urine cultures and blood cultures. So we wanted to make these data available to everyone. And I realize that in individual hospitals, that's not always going to be possible, but you can certainly make a version of these types of interactive antibiograms where you can say, for example, have hospital-wide and allow the user to drill down by a specific ward or by a specific specimen site, for example, urine or respiratory. And it is an issue, somebody had mentioned that if there's a specific region that has high rates of resistance, that could skew the overall results. And that's the reason why we wanted to be able to break it down. And we've broken it down in our province by 14 regions so that we can reflect that there is some degree of variability across regions. But just for the sake of providing a little bit of confidentiality for hospitals, we haven't gotten a total buy-in to release every hospital's antibiogram on the web. We're not drilling down finer than the regional level yet.
That's very helpful. Elizabeth, couple things. When you're changing practices for the nurses at the bedside about blood cultures, and you're implementing this, when the data comes back, do you share that with the clinicians at the bedside? I have that question. So that's at the bedside. But then I'd also like you to talk a little bit about, from an infection prevention perspective, how you use data, the antibiograms perhaps, in your surveillance practices. So speaking a little bit about, is there that feedback loop to the nurses when they're implementing appropriate diagnostic stewardship for culture draw? But then as infection preventionist, how you use the bigger, broader surveillance data?
So most definitely. In fact, we're trying to create, well, we're playing with a couple of different dashboards for the PICU project to see if we would be able to, one, look at those overall blood culture rates, look at it by central lines, and then actually look at contamination rates. So other infection preventionists are providing some data there. And then also repeated blood culture. So if they're done within a shorter window of time, how frequent that data are. And putting it in a dashboard format so then that the PICU can be able to access that information. It won't be real time because obviously someone has to do the analysis piece and share it, but at least on a monthly basis so that they can kind of look at all of that data together to see, are things helpful? And then also some of the process things too, which is related to that algorithm work, similar to what BrightStar has done. So yes, the data are shared back to the unit level, and that we do have COVID kind of slowed some things down, but some monthly meetings with them to kind of talk about, do we need to hone in that process, and then maybe conduct some interviews with staff to see where we might be able to improve. For the infection prevention side, one of the things that we're trying to do actually is link up stewardship data, antimicrobial stewardship data, as well as blood culture and surveillance data from the infection prevention standpoint to look at really more of an organizational health. And so that work is just becoming started. So I would say, right now, most of the work when we think about those trends are probably happening more at the HAC level. So that interdisciplinary group that's looking at CLABSI events, simply because that outcome data mostly affects that group right now. And there's already a framework to kind of support that. There was a question in the chat, if you don't mind, that kind of goes along, if I could link into it. And then but there was a question related to the interpretation of results too. And I'd be interested in what Dr. Langford suggests too, but with the rapid molecular diagnostic tests and then used for positive results, how are those results conveyed to the prescriber? And does microbiology contact the prescriber, nurse, or pharmacist? And then does the end user essentially know how to interpret those results? So I just want to speak to the nursing standpoint too. One of the things that we found is that when we did a study that looked across 9 different sites, one facility didn't want to participate because the lab would actually call the pharmacists and the providers would talk about these different types of results. And then the information would go back into the medical record. And then the nurse, if there was a drug change, they would only find out that way. I'm not saying that that's a right or wrong approach, but I think that that's a really important point that this individual has brought up, is that, each facility seems to be approaching this a little bit differently. I am starting to see some trends where the nurse is no longer receiving those positive results. The other point too is that, we know that it was interesting listening to your talk about MIC and, and seeing some of the comments in the chat too, is that, nurses, of course, have expressed a insecurity in being able to interpret the microbiology susceptibilities and so some of those results. But I think to this point is that I'm not sure that nursing programs, nurses, once they get into the clinical areas, actually are aware of how quick those results come back, which ultimately could promote some sort of practice change. Like I was taught the 3 days, after a certain point, then I'm going to look to see if the treatment changes. So I think that there's certainly a lot of work that probably needs to happen with frontline providers and letting them know like how these tests can be used, applied, interpreted, and responded to. So I really appreciated that because I think that's something I've wanted to explore within my own institution.
Yeah, Brad, do you want to comment on that with the rapid diagnostics? And, even with some of these, you can determine yes or no if they have a resistance gene profile.
Yeah, I'll just mention some work that's been done by Dr. Tristan Timbrook and colleagues. I know there's been lots of work done in the last few years by others that found that when reporting rapid diagnostic testing results, the impact on patient outcomes was much better when they're combined with an antimicrobial stewardship program. So somebody with clinical infectious disease expertise is available and able to relay these results to the prescriber and put them into context. So I don't really have a specific, it must be a pharmacist or it must be an ICP or a physician, but I think just to have that, that there's somebody relaying that information and providing some context with it is most likely to be impactful.
Is there anything in addition to that, Brad, that you normally, if you're using those types of tools, how you would how you guide the laboratory to report the data to the clinicians? Is that a part of your workflow?
Not particularly. I mean, in Canada, we do some rapid diagnostics, but not nearly as much as what's being done in the US. I know some stewardship programs that have made have a computerized program that can flag certain results. That can certainly be helpful. So if you have a patient who has an MRSA in the blood or Staph aureus in the blood or something, that can be quickly relayed to the stewardship team electronically. So I think use of technology can certainly help that as well.
Basically, at the end of time here, one quick question I'm going to sneak in, Brad, for you or Elizabeth, is around, and I think about this as like modified reporting, tailoring your culture for urine culture collection, and do you also have the capability then to determine whether it was catheterized or non-catheterized specimens? Do you differentiate those when they go to the lab and report out?
I'll quickly repeat. So I think it depends on the quality of the labeling in terms of whether it's a requisition or done electronically. That needs to be stated, along with the urine culture. I know that that's not always done properly, so that's definitely something that's really important, so that you can differentiate, is this catheterized or not, and decide on whether you can do a modified reporting. And certainly when you report out the results, it's important to know where it came from. So labeling is really key.
Elizabeth, do you have anything to add there before we close?
I really do.
Okay, that's no problem. I just wanted to let everyone that's still on, I've got the attendance code posted there, so you can go to ProCE, take the post test, and just do that by May 27th. And I've also posted it in the chat box. Let us at CIDRAP know if you lose this code or need a follow-up email sent. We usually send the code out to all those that are registered at the end of this. Slides will be, and this presentation will be available from our CIDRAP website. Importantly, I want to thank Dr. Langford for joining us and in describing his post-analytical work that he's doing. Dr. Monsees, your work on the pre-analytical and giving us that nursing and infection control perspective on this topic. And I think it's very clear from the two of you speaking how important it is for your two professions to be working together to solve these major problems within our health organization. So thank you so much, and thank you all your participants for joining us today.
Thank you.
Thank you.